Okay, so you know, I haven't, I skipped few weeks, so I collected some interesting cases. So this was a trauma case that came through. I forget exactly what was the trauma. So, you know, as you go through this case, you kind of see this, right? See it? Yes, no,
Yes. Yeah.
Okay, so that was
It's like a pseudoaneurysm or something.
right. Then we did some reconstructions. Let me just double check that the patient's name doesn't show up there. You can't see the name, right?
No.
Okay, I'll just zero in on this. So you can see we did kind of 3D reconstructions, and you can see this is the lumbar, right? And this is like a little pseudoaneurysm sort of arising from it, like that. Right. So then, okay, so patient has pseudoaneurysm, pretty cool. But the coolest part, at least for me, because I didn't grow up in the trauma center. Let's see, this is the correct side. So here we go. So as you look carefully, you can actually see that there's a fracture right at this level. So the fracture, like, so I guess, you know, and you see it right here. This is the fracture. And then somehow this little piece of bone just nicked the lumbar artery as it was passing through and created pseudoaneurysm. So I thought it was pretty cool.
That is very cool. I've never seen a fracture associated with one. That's cool.
That's pretty cool. All right, so
it's interesting that we don't see more.
Oh, he had other stuff.
No, I mean in general, like when we see these fractures, like that we don't see more pseudo. But I guess they just end up with hematomas and then they tamponade themselves off or something.
Right. All right. So the next. Okay, so this one, let's see. Oh, this one was an unusual case. The patient had cirrhosis. That's not the unusual part. You know, notice that he had, you know, gastric pneumatosis. Also not unusual part. What's unusual about is look at this paraumbilical vein, which is huge. But the kind of interesting part I've never seen before. Sorry, you can see that there are thrombi along the course of this huge recanalized paraumbilical vein. See that? So I've never actually seen this before, and this was new from the prior study. So I thought it was kind of very unusual and interesting thing to see.
Yeah, they probably wouldn't treat that, right? Like with
probably not.
Yeah.
Yeah, like look at that. Just a bunch of thrombi along the course of this thing. Although I don't know where they would travel if he were to travel them. So I don't know. Obviously, like these thrombi in and of themselves are not problematic, but if they travel somewhere, I don't know. All right. So
yeah, and then the gastric emphysema, you think it's probably just related to the NG tube?
No, he was actually pretty sick, and his lactate level was high, so that was an actual stuff.
Actual pneumatosis.
Okay, so this was an unusual case of it was MR with the only indication was prior architis. We have no history, like we have no clinical access to anything, so that was the only thing that we had. I don't know when the architis was, and I don't know what the symptoms are, but you know, as I was kind of sort of like, this is a silly indication. Check this out. So this patient has, this is his spermatic cord right there. And you can see that on the axials, this is the left spermatic cord and he's the right spermatic cord. And you can see there's hyperemia, hyperenhancement surrounding the right spermatic cord, little abscess right there. And you can actually see inflammation on T2 with fat set with surrounding edema. So this is a spermatic cord abscess, which is super rare complication of epididymoarchitis. I found like one case report that referenced like 3 or 4 prior case reports. So this is not common, but It's pretty cool.
Yeah, I haven't seen that either. That's really cool.
Yeah, and I unfortunately I don't know exactly what his symptoms were, what it is in relations in terms of when he had arthritis. His testicles looked pristine, so but must have had some sort of symptoms for them to send him for MR. All right, next case. Let me do this. Let me put this here. This way for sure I won't flash the identifiers. Next. Okay, cool. All right, so this is the case that I totally fell in love with because it was like pretty cool. All right, so this was a person who it was a CTU, and the history was, I forget, bladder cancer, something like that. History of bladder cancer. So we'll start with the kidney. And you can see that the kidney is markedly atrophic. And as you go down in the ureter, can you see it? See it?
Yeah, there's like a mass, like multifocal mass.
So there's multifocal TCC, and this is exactly what TCC kind of looks like. You see hyper-enhancing lesions along the urothelium. I mean, this is pretty extensive TCC, but that's not why this case is so awesome. So as you go up, you notice that the upper part of the kidney looks fine. So then you notice that this patient has duplicated collecting system. So then when you follow the second ureter, you get an unbelievable view of a normal and abnormal ureters right next to each other. You see it?
Yes.
So this is just an unbelievable case. You can see right next to each other what ureter should look like and what ureter should not look like. And this is where they join together. So this was a case of partially duplicated right renal collecting system with the lower moiety ureter just completely filled with tumor, and the upper moiety not. So I'm guessing, and this is totally guess on my part, but you can see that the cortex in the lower moiety is completely gone. So this is from chronic long-term obstruction, but the upper moiety is not. So I'm going to assume the tumor started superiorly, right? And so for a long time obstructed the upper moiety. The lower moiety was able to drain. And then eventually when the tumor extended inferiorly and started obstructing the flow distally, that's when the upper moiety began to be obstructed. And because there's not really cortical loss, this is not as long standing as the lower moiety.
So it's not like really like a Weigert-Meyer situation.
No, so this is partial duplication. Let's see if I can.
And there's something going on in the pelvis too, right? Is there something behind the bladder?
Just
the uterus. Okay.
So here's the again, let me set it up so you don't get to see that. So these are the reconstruction images I've done. So you can see here's the affected ureter, and this is the upper moiety ureter that joins here. So it's not I can never say it correctly. This is partial duplication. This is not full duplication, but this is the cool part. This is where they join, and you can see nicely the normal ureter right next to abnormal ureter.
Very cool.
Okay, you have to admit this is a pretty cool case.
It's very cool.
Okay. Let's see what I have. Hold on a sec. Oh, this was another interesting case. This was an inpatient ICU patient. I don't quite remember. Let's see. It was hypercalcemia, mesenteric ischemia, leukocytosis, malignancy, acute mesenteric ischemia. There's a bunch of questions about what's happening. So you can see that the patient has a little hematoma in her right adrenal, right? And then so you look at the second phase and it looks pretty similar. And when you move to the portal venous phase, you actually see a little active bleed. Sorry. So this was, I've never seen an spontaneous actively bleeding adrenal hematoma without trauma, without anything. But this is, you know, she was just sick and she just had spontaneous bleeding into adrenal hematoma. That's pretty cool.
That's cool. I have a couple of cases where I had like an adrenal hematoma on that side, and it was like when the adrenal gets compressed between the liver and the vertebral body, and like often there's like a liver lac and an overlying rib fracture, and then that's like the zone of pressure squishes that adrenal gland. But yeah,
right.
Yeah, this was just hypercoagulable, or sorry, she was just like having a bleeding diathesis.
Totally, you know, she's spontaneous, she's sick, and decided to bleed situation. So that was the interesting part, that it was actively bleeding, no history of trauma, just inpatient, just decided to actively bleed, which is an unusual clinical presentation. And I think this will be my last, but certainly not least. This is a young man who has history of spina bifida. You can see it here, and presents with small bowel obstruction. And, you know, very kind of strange looking bowel. And then you can see that his bowel protrudes here where he should not really be protruding. Let's see, sagittal. There, you can see it on the here, right? So you can see that the bowel loops protrude there, and you really should not have bowel loop going there. So he was obstructed, and you can see here the two, here's one point of obstruction and here's the second one. You see that? So this is dilated loop comes, and here's one transition point, and here's the second transition point. So this was just a wild case of small bowel obstruction, like this is internal hernia. You can see all the small bowel loops project here into the lesser sac and then actually go superiorly into the esophageal hiatus. And he had a closed loop obstruction from internal hernia. It's pretty cool.
Wow. Very cool.
Very cool, right?
Mm-hmm.
Right. So I think that concludes, hold on, I should double check. Yeah, this concludes my crazy case collection for today.
Thank you. That was awesome. I see more people have joined. Hi, Nelly. Hi, Steve. Hi, Kumar. Hey.
You had nothing to say about any of the cases?
Me?
Yeah, super cool. each of them. I have a quick companion case to share, Aarti.
Okay, go.
Companion to what Victoria showed, but I'm just going to be careful not to flash. Perfect. You know how, Victoria, the case that you showed with the umbilical vein thrombus, I just want to show how there is a diffusely infiltrating HCC in segment 4, and there is tumor thrombus extending into the recanalized umbilical vein. I don't have the multi-phase CT. It is there somewhere in the pile, but I just pulled up the portal venous phase here just to show you in contiguity this tumor thrombus extending into the recanalized umbilical vein. And then I have another quick companion case. I'm going to stop sharing for a minute.
Yes.
Excellent.
Yeah.
So this is an older gentleman, 69-year-old, who came in with right lower quadrant pain, had a CT, was found to have diverticulitis, and suspicion of a tiny perforation adjacent to the diverticulum, deteriorated in 2 days. And so the CT was repeated. And this is, they sent us a request, or rather we were reading this CT primarily on call on Saturday or Sunday, one of the days, last Saturday or Sunday. So as you can see, there are multiple dilated loops of small bowel. And then, you know, this is the segment of sigmoid colon with multiple diverticula. One of them has perforated, giving rise to an abscess in this region. And if you follow, let me see if I can get rid of, if you follow the course of this abscess, it tracks into the right hemipelvis, goes into the inguinal region and along the spermatic cord. So another funicular abscess or an abscess along the spermatic cord, but I've never seen a diverticular abscess tracking along the cord through the inguinal region like this. And they asked us to drain this abscess, and we were jokingly saying how on ultrasound, maybe we should just place a drain there. Sure enough, later we drained this component of the abscess, but just a cute companion case to Victoria's funicular abscess.
Yeah, Anu, what are you saying? Funicular?
Funicular, F-U-N-I-C-U-L-A-R. You know how spermatic cord infection or inflammation is called funiculitis? So this is like a funicular abscess.
I did not know it was called that, but a funiculare is like a train that goes up a hill. So
maybe the name comes from there. Yeah. See, you can clearly tell, Aarti, you're fond of traveling.
I know.
I didn't know that meaning, but funiculitis and funicular abscess.
Cool.
So that's it. No additional pearls here. I'm going to stop sharing.
Flo from Mount Sinai West says she thought the same thing for funicular. So I guess she's also a travel bug. Okay, does anyone else have cases, or I have a few, but I want
to. I can share a case.
Okay, great.
Okay, I'm gonna grab the screen. Would you be able to pause for a second? Can you see my screen? My screen's good?
Yes, I see four screens.
Yes, okay. So I want to know from the audience, what syndrome does this patient have? So here are the kidneys. The left is super atrophic, dysplastic. The right is also small.
Prune Belly?
Yeah, so good. Yeah. So then the anterior abdominal wall is underdeveloped. And then in the, I have an MR, so I'll show you the MR correlate. The ureter here is ectopic on the left. And then this here.
Nelly?
Yes.
Sorry,
yes.
so this irregular stuff, that's his reconstructed bladder?
Yes, sorry, yes. Hold on, I think it is, yes, and he has a posterior urethra. I think that we can see better on the MR, so let me bring this up. No, he didn't have, I don't think he had reconstructive.
Yeah, I was gonna say, it's really not reconstructed. It's
yeah, I'm sorry, it's not reconstructive, yeah. So patients with, we see the, he also have his renal pelvis is also a little ectatic distally. The ureters are minimally dilated. So patients with Prune Belly syndrome, they get like pelvic-calyceal and ureteral dilatation with renal dysplasia. They get the anterior abdominal wall musculature is like super underdeveloped, and they get bilateral undescended testes. So his testicles, this is the one on the left here. And then on the right, it's high up in the spermatic cord. Where is that little soft tissue? Let me pull it back still. We thought maybe it was this atrophic looking structure here. It's associated with like aneuploidy, and it's in the like clinically, they can, like I said, they can get ureteral dilatation, and they get like the kidneys are super dysplastic. Like in our case, they get an enlarged bladder, and they can get a urethral diverticulum as well. So here there's a little, his like seminal vesicles are abnormal, and then his prostate is here, and I think this is the urethral diverticulum. It looks it's a little bit off in line, but his seminal vesicles are a little bit not normal morphology either. So that's my prune belly. And then the second case.
Very interesting, Nelly. I do have one point about the undescended testicle. I used to
yes.
sometimes see, not in patients with prune belly, but just in
Mhm.
regular patients, I would see like a testis that was in the inguinal canal, and I was calling all these undescended testes. And then I realized that it was just moving up and down during the exam. So it was like a cremasteric reflex, like that some people.
Oh, retractile testes.
Yeah. So just don't overcall it like I was doing.
That's a great advice. But we don't get the dynamics, unfortunately. I mean, if you're doing ultrasound, then it's nice because you get.
Yeah, well, what I noticed was that like even over the course of the MRI exam, that would be moving.
Oh, that's a good point. Yeah, because it's
multiple
like,
sequences.
right, that makes sense. Okay, so this one, let me unshare. This is a patient with a liver lesion. So these are the pre-arterial, venous, and delayed. So no history of diffuse liver disease, like hepatitis or things like that. Patient, here's in an opposed phase. No, that's not in opposed. This one's in opposed. Okay. And there's signal dropout surrounding this area, so that this area is enhancing, and then there's also signal dropout. So there's like steatosis. So any thoughts on what this could be? So it enhances and it washes out, and then there's fat, intralesional fat.
Adenoma? It looks like the liver also might be fatty. Is it a female?
Right. Does he
This
have
is the boy, man.
looks like he has liver disease, right? Like
Yeah, it looks a little bit nodular, doesn't it? Yeah. But no hepatitis, no known history of hepatitis.
but he has fatty liver and evidence of maybe he has
NASH.
either NASH or he's drinks.
Fault. Yeah.
But then we have to bring up like HCC
Yeah.
versus adenoma.
Yeah.
Yeah. So this lesion was biopsied, and this came back hepatic adenoma with beta-catenin
Nice.
mutation. So it was an inflammatory adenoma, beta-catenin mutated, and had areas of well-differentiated HCC. So I thought this was a really interesting case, because when I see signal dropout, I always associate that with HNF1 alpha, like the steatosis site, right? Like adenoma. I didn't realize that you can get the beta-catenin that can arise from those type. And this one turned out to be inflammatory. I didn't know inflammatory adenomas can have intralesional fat. I thought that was really just HNF1 alpha subtype, but I guess you can.
Maybe it's like a combo. It seems like a combo
yeah.
of a steatotic inflammatory with also beta-catenin.
That's a good point. Yeah, maybe.
And Steve said he was worried about low-grade HCC, which you said that this was an adenoma with HCC in it, right?
Yeah, it was a inflammatory adenoma, beta-catenin. It must be, right? Because beta-catenin, I thought inflammatory and beta-catenin were like two different subtypes. And then on imaging, it looks like there was also probably.
Wait, Nelly,
I'm getting out.
Nelly?
Yeah.
I'm sorry. I think we got confused here. What was the final path? Beta catenin inactivated?
Yeah. So the final pathology, it says well-differentiated hepatocellular carcinoma arising from an inflammatory adenoma,
Oh, this sucks.
beta-catenin mutated.
Ouch. But adenomas in man have the highest probability of turning bad, unfortunately.
Nelly has a good question, and I'm wondering, Victoria, if you know the answer, or if anyone else. I also thought beta-catenin was like a different type than inflammatory, but it sounds like inflammatory can be beta-catenin activated.
I always thought they were separate categories, but I guess this one's probably one of those things where parts of part of the mass have different, different genetic mutations and stuff, and eventually something went bad with these mutations. That's my only explanation for this.
Cool. So are they going to do a right hepatectomy, or did they, or not yet?
Nelly, did they get any of the normal liver surrounding? I'm just curious if she.
Yeah, they had patient had mildly active steatohepatitis. So,
Yeah.
like you said, NASH, and then patient also had mild perisinusoidal fibrosis, so stage 1.
Yeah, so he doesn't. Yeah. Nicht good.
I'm muted. I'm unmuted now. So this is a Defico. And what do you guys think? And then let me give you the.
Any history of radiation therapy or surgery?
Yes. Patient has a history of an anal fissure that was surgically treated in the past. Patient also has a history of rectal prolapse and had physical therapy, pelvic floor physical therapy.
Well, her posterior aspect of her anal sphincter is completely fibrosed.
That's right. Yes, that's exactly right. So I really appreciate pelvic MR Deficogram, and I think it can be a lot more informative than Defico, fluoroscopic Defico, because we can get so much more anatomy. So as Victoria mentioned, here, this is the posterior compartment. You have the internal anal sphincter, and there's a scar down is like a complete defect. So patient has incontinence, fecal incontinence, and probably because, of this defect posteriorly. I mean, there's multi-compartmental issues in this patient, right? I mean, like the vagina should normally be H shape, and this one is kind of flat and sagging. So there's probably an endopelvic fascia defect. The urethra is midline. And then patient has pelvic floor dysfunction as well. So on the Defico, when the patient evacuates, there's prolapse. So I think we usually take the measurements like from the inferior pubic rami, and then you can do all the different measurements, which I have. I don't have this shown because it's going to show the PHI. So patient has probably a combination of anterior compartment findings, that like the vagina, we lose that normal H shape. So it's suggesting an endopelvic fascial defect, as well as posterior compartment problems, and the anal sphincter also, there's a defect that's probably causing her incontinence.
Was a case where we had sausage pancreas of the tail, retroperitoneal fibrosis around the aorta, and this mass involving the kidney, causing a little bit of ileectasis, so multi-organ with sausage pancreas. So this was IgG4 of multi-system IgG4, and could respond to a steroid trial. Okay, this is my next case. So this patient has a mass here. So what do you guys think about that mass? Sorry, I didn't hear you. What did you say?
Do you have a coronal, Aarti?
Mm-hmm.
There's like a central stalk.
I was going to raise the question of splenosis, but looks like there's a spleen there.
Yes, there's a spleen. It looks kind of like a spleen. It's got like a hilum, maybe little vessel going into it.
Castleman's. I had a Castleman's in this area that looked a lot like that too.
Oh, you're on a Castleman streak.
Maybe.
Oh yeah, let me see how it's arterially, if it's avidly enhancing. it's pretty enhancing, not super avid. Anything else?
It's sitting right next to the duodenum, so like a gist, but I don't see any connection to the duodenal wall there.
Good. So gist is always in the differential, but yeah, it's not, there's like a fat plane with the duodenal wall. Okay, so this was a nuclear medicine scan.
Is it dotatate?
Yes,
It's the endocrine neoplasm.
and it's really hot. So you think it's a neuroendocrine tumor?
I mean, if this that's as hot as it is.
Yeah, so anyway, they biopsied it and the biopsy came back neuroendocrine tumor and they resected it and it came back paraganglioma.
Whoa.
So the teaching point is, one, not just neuroendocrine tumors are hot on dotatate. It's actually very, very good for paraganglioma and pheochromocytoma as well. And also it is something that we should think about in this location, paragangliomas. And actually I have this cool companion case. So it was reminding
are they, like you said biopsy was positive for is it hard to separate those two?
Apparently so, yeah.
Biopsy?
So, yeah, they apparently have, they're both kind of like neuroendocrine origin, because they're like both neurogenic sort of. Yeah, there's on the FNA, it came back neuroendocrine tumor, and then on the final path, it came back paraganglioma. So there is overlap between those two. I don't know if it really matters, except that, you know, with the dotatate, you could say, oh, if it was a neuroendocrine, oh, so actually I do have a point here. That last case was a paraganglioma. This case that looks very much like it looks T2 bright, it looks kind of lobulated, it's like enhancing, it looks just like the other case, right? This was actually a neuroendocrine tumor nodal metastasis from an ampullary neuroendocrine tumor. So my teaching point is when you have a mass that looks like this in this location, please bring up a paraganglioma and neuroendocrine tumor. And two, if it is a neuroendocrine tumor, this is usually the nodal metastasis. So you have to go searching for the primary. You can't just take this out. So actually in this case, they biopsied it, it was neuroendocrine. And on EGD, they saw an ampullary lesion, which we really can't see on this MRI. And so they knew that they also had to go take out that primary duodenal neuroendocrine tumor as well. We have had other cases where the neuroendocrine's like in the duodenal bulb and then the big nodal met is out here. So it is good to bring up neuroendocrine and then search for the primary, but also know that paraganglioma can look just like it and can be right there. And can be hot on dotatate. Okay. This is my next one. So this patient was having abdominal pain. There's something in the liver here, next to the gallbladder. The major finding was this pelvic mass. This was the post-contrast. But you can see that there's also additional lesions like peritoneal deposits, and then this liver thing. And it was they were all very T2 bright. So I thought this was probably a mucinous.
Mucin, yeah.
Yeah, mucinous mets to the liver, mucinous peritoneal disease. And I thought this was like a big right ovarian mucinous mass. It's a little weird that an ovarian mucinous mass would metastasize to the liver.
Appendix?
Unless it's a GI source.
Exactly. So I shouldn't have fallen for it. And the appendix I didn't really see, and it was kind of normal, but what I did not initially see was this.
Rectum, yeah.
So this was actually the primary mucinous rectal tumor. And like on colonoscopy, it was like mucosally based, and then on all the stains, it was lower GI primary for mucinous tumor. So this ovarian thing was actually a metastasis. So I thought it was interesting because in this case, the ovarian met was like much bigger than the primary tumor. So I looked it up, and basically colon is not common to metastasize to the ovary. The most common are gastric and breast, like the Krukenberg tumors, especially signet ring cell. But about 4% of colon cancers can metastasize to the ovaries. They tend to have a poorer prognosis, and they're more chemo insensitive. The ovaries are actually kind of like a fertile ground for metastasis, and they're kind of chemo insensitive, so they do worse. So anyway, if you see a mucinous thing and if you see it in the ovary, don't just assume it's coming from the ovary. Always look, like Anu said, for the appendix, and then check the whole colon. And especially if it's metastasizing to the liver, think about a colorectal primary.
Aarti, how old was this patient? The only reason I ask is because this look of the mucinous rectal is common in younger adults.
Yeah, I read that too.
Yeah.
This patient was 60. So
okay. Didn't read that book.
yeah, 60 is starting to sound young to me, but
that's true.
Okay, and then this is my last case. So this patient, focus on the stomach. Actually, I'll start up here. You can see that there's a couple of different findings in the stomach. And there's one additional finding here.
Are they metastases?
From what?
Maybe melanoma?
Okay, good thought. I'll show you the coronal.
RCC?
Another good thought.
Yeah, they look kind of hypervascular.
And
I
there's
agree with
multiple.
Yeah.
Anything else?
Neuroendocrine again, like PNET, pancreas.
Yeah, so, and actually, hold on.
Type 1 gas, yeah.
Yeah, so Nelly, tell us, while I'm pulling up my PowerPoint here, tell us about the different types of gastric neuroendocrine.
There's like 3 types, I think. Type 1 is like the gastric type. And then, is that right? And then there's like 2 and 3, which are like the duodenal and more of the classic ones that we see.
Yes, so here is a little PowerPoint about it. So gastric neuroendocrine has 3 different types. Type 1 is the most common, and this is associated with atrophic gastritis. It's almost like the dip niche of the stomach, where you get multiple tiny little tumorlets. So they're usually very small. They have a very low risk of metastasis, and they have a lot of very high gastrin levels. So usually if they can bring down the gastrin levels, these little hypertrophic neuroendocrine tumorlets will go away. Type 2 is a gastrinoma, where you have a gastrinoma in the gastrinoma triangle, and then you get Zollinger-Ellison syndrome and proliferation in the stomach. And then type 3 is like a traditional neuroendocrine tumor. These tend to be larger, like this is an example of a hyper-enhancing type 3. And these have a very high risk of metastasis. And in general, let's see if I can go to my next slide.
Wow, 100% risk. That's something.
Yes, and then this atrophic gastritis, the one that causes the sort of hypertrophic type 1, can either be caused by H. pylori, so they can treat the H. pylori, or it can be caused by autoimmune gastritis, and they have kind of different locations. But anyway, the point is, actually, this patient had chronic atrophic gastritis on their biopsies. This is our gastric protocol, so we distended the stomach nicely with all this. You can do water or volumen, and you can see that we have multifocal nodules. These are larger than the typical type 1, but this patient had a background of atrophic gastritis. So they think this is type 1, and then this is the rare type 1 that actually has a metastasis. So this is a gastrohepatic nodal met. So in this case, they're treating the H. pylori to treat the background atrophic gastritis, and the largest one is here. So basically they did a partial gastrectomy to remove all of these, and they also removed the node. Okay.
Awesome case. I want to share my screen. Good. This is not really a diagnostic challenge, but I think there's like really great learning teaching points. Any thoughts?
Can you show us the T2? It looks
Yes.
like a big mass in the anal canal. Ooh, really dark.
Mhm.
Looks darker than a typical adeno.
Let me see if I can, here's axis.
It looks like an adeno involving the anal canal and going into the intersphincteric space.
Oh, you think it's a rectal that's going into the anal?
Or I think it's centered in the anus, but it's also involving that intersphincteric space.
So do you think it's an anal cancer or rectal cancer?
I think it's an anal cancer. I don't know.
Wait, okay, gotcha. Great.
Anal.
Yeah, yeah, so exactly. So I mean, this is an anorectal tumor. And it, yeah, there's invasion of the, this is internal sphincter right here. So those are some key differences between anal and rectal cancer. So anal is usually a squamous, whereas rectal, we usually think about as adenocarcinoma. So there are different subtypes. And then the way we do the TNM staging is also different. So in, rectal, we look really into like sphincteric involvement because it'll, determine if they can do a sphincteric like preserving surgery or not. And we kind of like look at the intersphincteric space. And then we look into the depth of invasion, right? If it has serosal involvement, that becomes T3. In anal cancer, which is what this is, we don't look at depth of invasion for T staging. We look at the size. So this one was, I think 7 centimeters. The nodal staging is also different. So in rectal cancer, the end staging is depending on the number of nodes. In contrast with anal cancer, it's the location of nodes. And we have to look at the inguinal canals because that's usually a common site for anal cancer involvement. And treatment is different. So with rectal cancer, depending on if they have T3, then we do like neoadjuvant chemoradiation, and then depending on what country you're in, they'll do surgery subsequently. In contrast with anal cancer, the standard is just radiation. They don't do surgery for anal cancer. So those are some of the key differences in the TNM staging between anal cancer, which is what this was, compared to rectal cancer.
And Nelly, this was an anal squamous cell because there can be anal adenos, but this was a squamous.
Yeah, this was a squamous. So then this case, as you mentioned, it involves the anal sphincter and it also invades the lower rectum. The invasion of the lower rectum doesn't change the staging. It's, again, just the size, which determines which T stage they are.
Cool. And then one thing I learned at SAR, which I didn't know before, is that there is a SAR rectal DFP. They have a different template for the rectal cancer and then a different template for this anal, in anal cancer. And that's, yes, they're both really useful.
Very useful.
Online.
I use both for my templates.
Cool. Anyone else? Okay. Have a great day, guys. Bye.
Thanks all.
Thank you.